Andrew Kroger is a medical officer for the National Center for Immunization and Respiratory Diseases at the Center for Disease Control and Prevention. As one of the traveling trainers in the Communication and Education branch, Dr. Kroger has given multiple presentations on topics ranging from immunization updates to pandemic influenza preparedness. Most notably, Dr. Kroger is the author of the newest edition of CDC's General Recommendations on Immunization, and he is also involved with some of the new distance learning activities of the branch, including the Current Issues in Immunization series that is delivered through net conferencing. Dr. Kroger trained in pediatrics for 2 years at Rainbow Babies and Children's Hospital in Cleveland before transferring to Emory University, where he specialized in public health and preventative medicine. He received Joint Doctor of Medicine and Master of Public Health degrees from Yale Medical School and Yale University School of Epidemiology and Public Health with the concentration in international health. Thank you, Dr. Kroger. We are very excited to have you today.
Thank you very much, Marin. Hello, everyone. This is Andrew Kroger, and I'm very pleased to give this presentation today on influenza vaccines. So by way of an overview, I'm going to first discuss influenza disease, microbiology, symptoms, and signs, then follow with a discussion of the specific influenza vaccines for this season, as well as ACIP's recommendations for the 2020-2021 influenza vaccination season. I am going to also discuss vaccination guidance in the context of the COVID-19 pandemic. And I also have a couple of slides that I'll conclude with a discussion of NCIRD's Vaccinate with Confidence program. Influenza is a highly infectious viral illness. The name influenza originated in the 15th century Italy from an epidemic which was attributed to the influence of the stars. The first pandemic, which is a worldwide epidemic that clearly fits the description of influenza, occurred in 1580. There were at least 4 pandemics of influenza in the 19th century and 3 in the 20th century. The pandemic of Spanish influenza in 1918 caused at least an estimated 50 million deaths worldwide, and likely more than that. The pandemics in 1957 and 1968 were of lesser severity. The first pandemic of the 21st century occurred in 2009 with the H1N1 virus. In spite of the overwhelming burden of influenza disease, we have been vaccinating to control influenza for decades. The first influenza virus was isolated in 1933, and a vaccine was developed in the 1940s. It was first developed in 1945. The influenza virus is a single-stranded, helically shaped RNA virus of the Orthomyxoviridae family. The viral nuclear material is what determines the basic antigen types, and the 4 types are A, B, C, and D. Type A influenza can be categorized into subtypes that are determined by surface antigens or proteins, and the 2 proteins are called hemagglutinin and neuraminidase. Hemagglutinin is a protein that mediates viral attachment to human cells. There are actually 18 types of hemagglutinin, although the 3 most common in viruses that infect humans are labeled types H1, H2, and H3. Neuraminidase is a protein that has a role in viral penetration into the cell. There are 11 types of neuraminidase, although the 2 most common in viruses that infect humans are N1 and N2. Here are some differences among the 4 types of influenza. Type A influenza causes moderate to severe illness, and it can affect all age groups, and it infects humans and other animals. Actually, birds are the reservoir for influenza, type A. Type B influenza causes milder epidemics, changes less rapidly than type A, and only affects humans and primarily affects children. Type C influenza is rarely reported in humans. It does not cause epidemics or pandemics. And there is actually a type D influenza. This does not cause disease in humans at all. It primarily affects cattle. Here you can see an illustration of an influenza type A virus. Virus strains are named in order by the virus type, A or B, their geographic origin, the strain number, the order in which that strain was identified by the laboratory in which it was first identified, the year in which the virus was isolated, and then for specific type A viruses, we then label the strain with the subtype defined by the type of hemagglutinin and neuraminidase. So for example, the strain you see here is a type A California 7 2009 H1N1 subtype. The process of change, and by this we mean mutations in the hemagglutinin and neuraminidase proteins, can be labeled by the terms antigenic drift or antigenic shift. This affects the viruses that we see that circulate. And drift is responsible for minor changes. These changes occur every year, and drift is caused by point mutations in the gene and may result in an epidemic. Antigenic drift results in the influenza epidemics that we see every year. This type of mutation can occur in both influenza A and B viruses. However, antigenic shift can cause a major change, and when this change occurs, we generally label the strain with a new subtype. This type of genetic change is caused by an exchange of entire gene segments, and it occurs in species other than a human, so it occurs most commonly in birds and pigs, that can be infected with multiple subtypes simultaneously, and this type of exchange results in a pandemic because of the creation of a novel strain. Antigenic shift only occurs in influenza A viruses. "11 years ago, in 2009, the H1N1 pandemic was declared by World Health Organization. It was in April. This was a novel influenza type A virus that appeared and quickly spread across North America. It wasn't considered novel because of completely new hemagglutinin and neuraminidase. Actually, we'd had circulating H1 for years, but because of other antigens that were actually in the virus. By May of 2009, the virus had spread to many areas of the world. This was the cause of the first influenza pandemic since 1968. As you may recall, or you may have participated in, pandemic monovalent influenza vaccine was rapidly produced and deployed in a nationwide vaccination campaign. Transmission of influenza virus is by the respiratory route. After invasion of the respiratory tract, replication occurs in the cells of the respiratory epithelium with subsequent destruction of these cells. Viremia or bloodstream infection is rarely documented with influenza, and influenza viruses are shed in respiratory secretions for 5 to 10 days. Clinical features of influenza include symptoms that occur after an incubation period of 2 days. It may range from 1 to 4 days. And 50% of persons develop the classic symptoms. And by classic, what we're talking about is abrupt onset of fever, which it can usually be a high fever, 101 to 102 degrees Fahrenheit, or even higher sometimes, myalgia, sore throat, non-productive cough, and headache. Other symptoms can include extreme fatigue, prostration, and again, I'll emphasize the fever usually occurs very abruptly so that the exact hour is often recalled by the patient. The myalgias I've mentioned mainly affect the back muscles. The cough is caused by the epithelial destruction that I mentioned in the respiratory tract. Some other symptoms include rhinorrhea, runny nose, headache, substernal chest burning, and even ocular symptoms can occur, eye pain and sensitivity to light. And the illness usually lasts between 3 and 7 days. Complications of influenza illness include pneumonia. This is the most frequent complication, and it's most commonly a secondary bacterial pneumonia, usually caused by the bacteria Streptococcus pneumoniae, Haemophilus influenzae, or Staphylococcus aureus. Primary influenza pneumonia caused directly by the influenza virus is uncommon but has a very high fatality rate. Other complications include Reye syndrome. This occurs almost exclusively in children taking aspirin, and they take aspirin when there is a concomitant viral infection, and influenza B is a viral infection that has been associated with Reye syndrome. Varicella zoster, chickenpox is another. This presents with severe vomiting and liver toxicity, which leads to encephalopathy, confusion, which can progress to coma with pathologic swelling of the brain. Other complications may include myocarditis, which is inflammation of the heart muscle, and worsening of chronic bronchitis and other chronic pulmonary diseases. Death is reported in less than 1 per 1,000 cases, and the majority of deaths typically occur among persons 65 years of age and older. The number of influenza-associated deaths varies substantially by year, virus type, subtype, and the age group affected. Since 2010, the estimated number of annual influenza-associated deaths has ranged from a low of 12,447 in 2011-2012 season to a high of 61,099 deaths in the 2017-2018 season, with an average of 30,877 annual deaths. Persons 65 years of age and older account for 80% of those deaths, and deaths are there are 2.7 times as more deaths that occur in seasons when type A H3N2 viruses are prominent. The highest rates of complications and hospitalization occur among persons 65 years and older, but also occur commonly in young children and among persons with certain underlying medical conditions, chronic diseases such as heart or lung disease. Between 2010-2011 season and the 2015-2016 season, flu-related hospitalizations in the United States ranged from a low of 140,000, which was during the 2011-2012 season, to a high of 710,000 during the 2014-2015 season. The following season, the 2015-16 season, CDC estimated 310,000 people hospitalized for flu-related illness. 50% of the hospitalizations in 2015-16 were among persons younger than 65 years. And like deaths, a greater number of hospitalizations occur during years that the H3N2 subtype is predominant. Besides chronic heart, chronic lung disease, other groups at increased risk of influenza complications include children age 6 through 59 months and adults age 50 years and older. Note, children under 6 months of age are also at high risk, but this group cannot be vaccinated. So it's really birth through 59 months. Persons with chronic pulmonary, which includes asthma, or cardiovascular, which excludes isolated hypertension, renal, hepatic, neurologic, hematologic, or metabolic disorders, which is inclusive of diabetes mellitus, they're all at high risk. Immunosuppressed persons are at high risk. Women who are or will be pregnant during influenza season. Children and adolescents from age 6 months to 18 years who are receiving aspirin therapy because they might be at risk for experiencing Reye syndrome after influenza virus infection are at high risk. Residents of nursing homes and other long-term care facilities, American Indian, Alaska Natives, and persons who are extremely obese with a body mass index greater than or equal to 40. School-age children have high attack rates during community outbreaks, and they serve as a major source of transmission of influenza within communities. And there are numerous reports of influenza outbreaks which begin in schools and spread to the communities outside the schools, and then we see the outbreaks slow or stop when schools close for the winter holidays. The reservoir for influenza is humans and animals, type A only. The primary reservoir, as mentioned, are birds, but other animals, many mammalian species, can serve as at least intermittent hosts, such as horses, dogs. Transmission is by the respiratory route, but also can probably be transmitted through airborne droplets, the smaller droplet nuclei. There is a temporal pattern with a peak from December to March in temperate climates. This pattern may shift earlier or later, of course. Peak months for influenza activity in the United States since 1982 have been in descending order. February is the highest number of cases, December, March, and then January. Communicability occurs 1 day before to 5 days after the onset of symptoms in adults, but it can last longer in children. Influenza virus infection cannot be diagnosed accurately based on signs and symptoms alone. Laboratory testing is necessary to confirm a diagnosis. This could include virus isolation. That's essential for surveillance, for virologic surveillance. Appropriate clinical specimens used for virus isolation include nasal washes, nasopharyngeal aspirates, nasal and throat swabs, tracheal aspirates, and bronchoalveolar lavage. Virus isolation does require several days, so it is not very useful for clinical decision making. Serum specimens are required to do serologic diagnosis of influenza virus infection. So this is generally a research tool. IgG serologic testing is really not useful for clinical diagnosis. To use IgG to make a diagnosis, you also have to know the patient's vaccination history. You have to draw the acute phase serologic specimen within a week of the onset of illness, preferably within 2 to 3 days after onset. The convalescent phase sample has to be collected approximately 2 to 3 weeks later, and a positive result is considered a 4-fold or greater rise in the titer between the acute and convalescent phase samples to one type or subtype of the virus. This table, adapted from the CDC Influenza Diagnostics website listed at the bottom of the slide, lists the most commonly used diagnostic tests for influenza, beginning with traditional viral culture using a cell culture. There are a number of other tests listed on this slide that give results more quickly than viral culture. I'm only going to discuss 2 other types of tests, the ones that are where the methods are listed in underlined green. First, reverse transcriptase polymerase chain reaction, or RT-PCR, is the most sensitive method for the detection of influenza virus and is the gold standard for influenza diagnosis. The use of molecular techniques to directly detect virus in respiratory samples can provide rapid identification of viruses that's within hours, if not faster. And then there are the rapid influenza diagnostic tests, and these are commercially available. They detect for the presence of viral antigens. These tests are usually less sensitive than RT-PCR testing. Currently available rapid tests do fall into 2 groups that either detect both A and B viruses, but they don't differentiate between the 2, or they can detect both A and B, and they do differentiate between the 2. And results of these tests can be available in 15 minutes or less. So the rapid diagnostic tests help in the diagnosis and management of patients who present with signs and symptoms compatible with influenza. They're useful for helping to determine whether outbreaks of respiratory disease, such as in nursing homes and other settings, might be due to influenza. There are many brands of these tests which detect influenza antigens or proteins, and they are widely used in clinical settings. The sensitivities of the rapid influenza tests are approximately 50 to 70%. Specificity of influenza tests are 90 to 95%, and that's compared against viral culture or RT-PCR. If they're positive, they have most likely detected true influenza infection. They have a good specificity. However, if these tests are negative, they may miss an influenza infection about 30% of the time or so. This graph is just a reminder about influenza surveillance. This will start in earnest. The reporting usually begins in October. This is just one of many CDC surveillance systems for influenza. This one measures laboratory data and helps characterize the current season's subtypes and types. Other surveillance systems examine cases, hospitalizations, and deaths. CDC and its state and international partners conduct influenza surveillance to monitor the presence of circulating strains and to detect new strains. This helps in strain selection for new flu vaccines. It also estimates influenza-related morbidity, mortality, and economic loss, can rapidly detect outbreaks, and can assist disease control through rapid preventive action. There's a lot of variation in the effectiveness of influenza vaccine among different age groups and with respect to specific outcomes. An activated vaccine is considered about 40 to 60% effective among all age groups. The inactivated vaccine is 74% effective in preventing pediatric intensive care unit admissions. When we get to adults, the prevention is not as good as in children. It's 40% effective generally in preventing hospitalization among adults. But for severe disease, it's quite good, 82% effective in preventing intensive care unit admissions, and 80% effective in preventing death among the elderly. So now I would like to discuss the influenza vaccines for the 2020-2021 influenza season. Here are the strains for the quadrivalent vaccines listed on the slide. By way of some background, I've mentioned that there are two types, type A and B, that routinely spread in people that are responsible for seasonal flu epidemics every year. I talked about the subtypes already. There are two primary subtypes that circulate for type A in a given year, and two lineages of type B that co-circulate in a given year. And so most of the vaccine that we have will be quadrivalent, and you can see the strains listed in the quadrivalent products. The egg-based vaccine will contain the Guangdong Mountain strain of H1N1, the Hong Kong strain of H3N2, the Washington strain will be the Victoria lineage of the type B virus, and the Phuket strain will be the Yamagata lineage of type B. Note that for the cell culture and recombinant quadrivalent vaccines that will be available, and I will discuss in a moment, they contain the same four strains, except the H1N1 is called the Hawaii strain, which is a Guangdong Mountain-like strain. The trivalent vaccine will have these strains, but it will not have the Yamagata lineage. All three strains, the two type A subtypes and the Victoria lineage in the quadrivalent vaccines are updated and new this year and are based on surveillance that has been performed the previous year. So there are a number of different types of vaccine. Here are some abbreviations that you may see when you read the ACIP influenza statement. We have IIV, which stands for inactivated influenza vaccine. There's LAIV4, which is the live attenuated influenza vaccine. RIV4 is the recombinant influenza vaccine, and like inactivated influenza vaccine, it is non-live. And then you will see some prefixes for these products. SD will stand for standard dose, HD high dose, A stands for adjuvanted, and CC stands for cell culture based. There will be numeric suffixes that follow the abbreviation, and that indicates whether a vaccine is trivalent or quadrivalent, respectively, if it's 4 or 3. And so the different formulations that are out there are all approved for different age groups. The IIV stands for the inactivated influenza vaccines. This vaccine contains inactivated virus that's produced either by splitting or generating a subunit, and that difference is really not consequential. There are two there's the enhanced high-dose vaccine, and then there's standard dose vaccine. Vaccine can be trivalent or quadrivalent. It can be unadjuvanted or have an adjuvant, which enhances the immune response. Inactivated vaccines can be egg or cell culture based. And so there are many, many brands out there. Some of them are approved for those as young as 6 months of age. I'll talk about those in a moment. And these vaccines are all administered intramuscularly. Then there's RIV4. This is the recombinant vaccine. It's recombinant hemagglutinin protein. You can't really consider it inactivated. It was never obtained from a whole virus, but it is non-live. It was never isolated or grown in egg, so this vaccine is egg-free. It is quadrivalent and is administered intramuscularly. LAIV4 is an intranasal live attenuated influenza vaccine, which is going to be recommended with the other vaccines this year. As you know, 3 years ago, we were not recommending this vaccine. The manufacturer had to make an improvement on the replicative thickness of the strain, which they have done. So now this is another vaccine that can be used this year. A quick aside about influenza vaccines for those children between 6 months and 35 months of age. There's two potential points of confusion that always come about when using these products. First of all, I've got the specific products listed, and the first point of confusion that occurs is keeping straight the volume for a dose. There are 4 licensed products that are out there. The dose volume differs. Afluria is a 0.25 ml volume. Fluarix is a 0.5 ml volume. Flulavol also 0.5 ml, and then Fluzone is available in both a 0.25 ml and a 0.5 ml dose. And you can use either one. There's no preference for one versus the other. But you want to keep, when you use a given brand, you have to use the correct volume. So that's the challenge with that. The history behind Fluzone: it was originally manufactured as a whole inactivated virus, so not split and not subunit. And due to reactogenicity considerations, it was packaged as a 0.25 cc dose. But this year, the manufacturers have, in fact, transitioned to a 0.5 cc dose, although there are some 0.25 cc volumes still around, and those can be used. The other point of confusion is that the dose volume is distinct from the number of doses needed. So a child 6 months through 35 months of age who is recommended for 2 doses of influenza vaccine will still need the second dose of vaccine 4 weeks later. So, the volume has nothing to do with how many doses. Just because the volume is 2 times as big, it does not mean that you get out of giving a second dose of vaccine. So keep those 2 issues distinct because they're very, very different. There has to be a 4-week interval between the 2. We're talking about priming and boosting the response. There are some changes this year to the influenza formulations, and so I haven't listed all of the package information for all of the brands, but I've talked on the slide about what's changed. So this year, an important change is both high-dose influenza vaccine and adjuvanted influenza vaccine are available as a quadrivalent formulation. So now all enhanced vaccines, which are those two plus the recombinant, they all exist as quadrivalent vaccines. An important point, the only trivalent formulation that's left is the adjuvanted influenza vaccine. And I just mentioned adjuvanted vaccine as quadrivalent. So what's important to note is that this product exists as both a trivalent and a quadrivalent formulation. And there's no preference for one versus the other. Another change, the volume of high-dose quadrivalent vaccine is now 0.7 ml. Last year it was 0.5 ml. The maximum number of vial entries into a Fluria multi-dose vial is 20. I know that recently it was 10 because I looked it up, but it has changed. At least within the past few months, it changed from 10 to 20. So you can take 20 doses out of a Fluria multi-dose vial. The last change is that the Fluzone is not available in 0.25 ml pre-filled syringes. Only 0.5 ml pre-filled syringes are available. Last year it was available as both. So moving on now from a discussion of the vaccines to the ACIP recommendations for influenza. Routine annual influenza vaccination is recommended for all persons 6 months of age and older who do not have contraindications. That is our core recommendation, and it has not changed since last year, and it has been this way for a long time now. While vaccination is recommended for everyone in this age group, there are certain groups for whom vaccination is particularly important. This does include anyone who is at high risk of complications and severe illness for whom the vaccine is licensed. So people 6 months of age and older can be considered a priority for vaccination. Also, contacts and caregivers of persons at high risk, and of course the contacts and caregivers of infants younger than 6 months, because there's no vaccine approved for children younger than 6 months, so their contacts have to be protected. Influenza vaccine has been specifically recommended for pregnant women since 2004, even before we had a universal recommendation. They are at high risk for cardiopulmonary complications from influenza disease because of their reduced lung capacity. The physiologic state of pregnancy obviously causes an increased cardiac stroke volume, so the heart is working harder. So they're at higher risk of complications if they were to develop influenza disease. And also, the state of pregnancy reduces relatively the immune response against invading pathogens. There's a shift from one T helper state to another, and so this is another reason why pregnant women are vulnerable to infection, and so we recommend influenza vaccine. The recommendation for this vaccine is limited to the inactivated influenza vaccine product, or RIV4, the recombinant. LAIV4 is not recommended for pregnant women. In fact, it is contraindicated for pregnant women. Influenza vaccination is very important in the context of the COVID-19 pandemic. And I'm not going to talk about all of the recs yet and how they're changing, but I did want to talk about this one specifically in advance because there is a recommendation for specific groups. We want to use every opportunity to administer influenza vaccine to eligible persons to reduce the burden on hospital emergency rooms and intensive care units. And so there's also a prioritization for influenza vaccination, in addition to what I've already talked about. Also essential workers, which includes healthcare personnel and other critical infrastructure workforce. Persons at increased risk for severe illness from COVID-19. which includes older adults and those with underlying medical conditions. And those medical conditions are specifically listed on the first URL that you see at the bottom of the slide. Also, recommendations can be prioritized to members of certain racial ethnic minority groups, and the second URL lists what those groups are. Persons at high risk for influenza complications, I've already kind of discussed those specific medical groups as well. So, when you add up all of these groups, you probably do approach the entire population 6 months of age and older, I must say, these groups and the ones mentioned on the earlier slides. So kind of brings us back to the core recommendation, but I did want to definitely share this information with you. Now, the timing of vaccination, you want to make sure that vaccination occurs before the onset of influenza activity, when disease really starts to peak. And we don't know when that is going to be always. So we make a recommendation that healthcare providers should make sure they offer the vaccine by the end of October. So the time is now to vaccinate. To avoid missed opportunities, we make a general recommendation that vaccination should be offered during routine healthcare visits and hospitalizations when vaccine is available. And you don't stop November 1st. Organized campaigns can occur throughout the season, of course, in November through December and even into the following year. Note that those groups that should receive the earliest doses of vaccine are children 6 months through 8 years of age that require 2 doses. They have a 4-week interval between the 2 doses, so you have to start early for that group. And vaccination in July and August might result in suboptimal immunity, but that's for those 65 years old and older. So make a note of that. September is the best time to start vaccinating for those 65 years old and older. And again, continue to offer flu vaccine as long as you have unexpired vaccine available. So for persons with egg allergy, we have an important change this year, which it's essentially the 4th sub-bullet here, but let me just kind of talk about our recommendations generally. For all vaccines, IIV, RIV4, and LAIV4, the quantity of ovalbumin or egg protein is exceedingly small. It is not a concern to allergists who are the experts on anaphylactic allergy. And so, we don't want those who have a history of egg allergy to have difficulties with vaccine access. So we do recommend, as we have every year, that those who report a history of egg allergy should still receive influenza vaccine. Patients with a history of severe allergy to egg, and this is if the symptoms are described as worse than hives, we recommend that the selected vaccine should be administered in an inpatient or outpatient medical setting. This is including, but not necessarily limited to, hospitals, clinics, health departments, and physician offices. And we want vaccine to be administered and supervised by a healthcare provider who is able to recognize and manage severe allergic conditions. This year, we added a sentence in our recommendations that RIV4 and CCIIV4, the cell culture-based vaccine, are excluded from these considerations of setting and supervision. These vaccines are completely egg-free, and so therefore there's really not any reason for concern about egg-based anaphylaxis. So that was a change that was made this year. There's not really a post-vaccination observation recommendation on the basis of anaphylaxis. Indeed, anaphylaxis can occur hours later, and so it kind of creates a false sense of security to have people waiting for that reason. However, syncope and fainting is real, and so we have a recommendation anyway and I should say it's a consideration that providers should have patients wait 15 minutes to avoid injury due to syncope or fainting. Make sure when vaccine is received, because this does generally occur within the 15 minutes, so it occurs quickly. While receiving the vaccine, have your patients sitting down, or if it's an infant, lying down, to avoid injury due to syncope or fainting. This is our algorithm for children aged 6 months through 8 years of age. And it hasn't changed this year. It's similar to the past 2 seasons. If a child between the ages of 6 months through 8 years has received 2 cumulative doses prior to July 1st, 2020, then they're only going to need 1 dose for 2020-2021. Only 1 dose is needed after the 9th birthday. Now, for children who are 8 years of age and in the current season, let's say they're recommended by this algorithm to require 2 doses for the current season. If they receive the first dose and then they turn 9 years of age, we do recommend that they receive dose number 2. It'll be the only one that they receive for that season after 9 years of age. So, as mentioned, only 1 dose needed after the 9th birthday, but these children actually are going to receive a total of 2 doses for the current season. They turned 9 during the season. This is relatively, within the past 5 years, a new recommendation. We are harmonized with the American Academy of Pediatrics, who wanted the recommendation to read this way. As influenza does circulate year-round in the tropics, we have specific influenza vaccine recommendations for travel to the tropics. Also, the Southern Hemisphere, there are considerations since it's a different strain usually circulating and a different vaccine. So we do recommend this vaccine for travel. For travel to these locations, you should receive the current year's vaccine unless you've already received it in the current influenza season. You don't need an additional dose necessarily if you've been vaccinated for the current season. Travel to the Southern Hemisphere vaccine would be ideal. It may be a drifted strain, and it may be a different vaccine formulation than the Northern Hemisphere vaccine. We actually don't care about that consideration, whether it's different or not. If you could obtain the Southern Hemisphere vaccine for travel to the Southern Hemisphere, you should receive it. This can be a challenge, though. There's one brand that's licensed, and it's not available in the U.S. So, but we do get this question a lot, so I tried to kind of clarify some of the issues here. Northern Hemisphere vaccine would be an alternative, but again, you don't need another dose if you've already been vaccinated with the Northern Hemisphere vaccine in the current season. But it might be an alternative for a traveler who missed vaccine and now it's June and they're traveling, or it might be an early dose in July with the new formulation if they're going to be traveling and they can't get the Southern Hemisphere vaccine. So there are a couple recommendations here. LAIV is a live vaccine, and our general recommendation is it can be given basically on the same clinic day as any other vaccine. So that's convenient. However, as a live vaccine, it needs to be separated from other live vaccines by 28 days. Inactivated influenza vaccine and recombinant influenza vaccines are not live, so they can be administered simultaneously or non-simultaneously with any other vaccine. For patients 65 years old and older, concomitantly receiving Shingrix, we say that providers can consider a different brand than Fluad going to be receiving Shingrix. Both Shingrix and Fluad contain novel adjuvants, but if there's no other brand than Fluad available, then you should vaccinate with Fluad, even if it means simultaneous vaccination with Shingrix. There's been some concern about the risk of reduced effectiveness with IIV and PCV13 administered simultaneously. What reduction in immunogenicity to pneumococcal strains? It's only seen in a few strains, and it's only seen in adults. And adults that are indicated for PCV13 are high risk for invasive disease. So you really do need to vaccinate simultaneously with IIV and PCV13 if both are indicated. For influenza effectiveness, there's been also some concern with influenza and PCV13. The study that showed reduced immunogenicity actually didn't control for previous exposure to influenza, so the data are not strong, and so this really also is not a concern. You should administer the vaccines simultaneously. There's been concern about IIV and DTaP being administered simultaneously because of increasing the rate of febrile seizures. Since patients that are indicated for these two vaccines are at high risk of complications from vaccine-preventable diseases, the concern about increases in febrile seizure does not justify withholding either vaccine, so they should be administered simultaneously. Adverse reactions to the inactivated influenza vaccine, they could be local reactions, soreness or redness. This occurs in 15 to 20% of vaccine recipients. Fever, malaise, and just systemic reactions occur in less than 1%. Notably, this is not influenza infection. These reactions that are seen are always milder than actual influenza illness. You can't get flu from the flu shot. Allergic reactions, hives, angioedema, anaphylaxis are rare, occurring in about 0.45 to 2 per million vaccinated persons. Guillain-Barré syndrome is a peripheral neuropathy. Its incidence in the general population is low. Persons that have a history of GBS have a substantially greater likelihood of subsequently developing GBS than persons without such a history, and that's irrespective of vaccination. As a result, the likelihood of coincidentally developing GBS after influenza vaccination is expected to be greater among persons with a history of GBS than among persons without a history of GBS. Whether the vaccine is causally related to the risk for recurrence is not known, so we make it a precaution that if those who have developed GBS within 6 weeks of a previous influenza vaccination, and if they are not at high risk for complications from influenza, you may want to look at other methods for prevention of influenza. But for those at high risk for severe complications from influenza, the established benefits of the vaccination do justify yearly vaccination. And if you're not going to administer it, then you do have to drop back on antivirals, which I will discuss. Adverse reactions to LAIV vary by age. In children, there has not been a significant increase in upper respiratory or URI symptoms, fever, or other systemic symptoms. We do see an increased risk of wheezing in children 6 through 23 months of age, which is why LAIV is only recommended for 2 years of age up until 49 years of age, or through 49 years of age. For adults, there's a significantly increased rate of cough, runny nose, nasal congestion, sore throat, and chills among vaccine recipients. There has not been an increase in the occurrence of fever, and no serious adverse reactions have been identified for children or adults after administration of LAIV. So the contraindications and precautions for the inactivated influenza vaccine and RIV4 include one contraindication, a severe allergic reaction, for example, anaphylaxis, to a vaccine component or following a previous dose of an activated influenza vaccine. And precaution includes moderate or severe acute illness or a history of Guillain-Barré syndrome within 6 weeks following a previous dose of influenza vaccine. LAIV contraindications include a history of a severe allergic reaction to any component of the vaccine or after a previous dose of any influenza vaccine, concomitant aspirin or salicylate containing therapy in children and adolescents, children aged 2 through 4 years who have received a diagnosis of asthma or whose parents or caregivers report that a healthcare provider has told them during the preceding 12 months that their child had wheezing or asthma, or whose medical record indicates a wheezing episode has occurred during the preceding 12 months. Children and adults who are immunocompromised due to any cause, and that includes immunosuppression caused by medications or by HIV infection. Close contacts and caregivers of severely immunosuppressed persons who require a protected environment. Pregnancy, receipt of influenza antiviral medications within the previous 48 hours for the two antivirals oseltamivir and zanamivir. This interval is 5 days for peramivir, and it's 17 days for baloxavir. Cerebrospinal fluid leak is a contraindication, and so is cochlear implant. Precautions to LAIV include moderate to severe acute illness with or without fever, a history of Guillain-Barré syndrome within 6 weeks of receipt of influenza vaccine. So those two are the same. There are also precautions for the inactivated and RIV4. Asthma in persons 5 years of age and older is also a precaution to LAIV. And then other underlying conditions that might predispose to complications after wild-type influenza infection. For example, chronic pulmonary, cardiovascular, which excludes hypertension, renal, hepatic, neurologic, hematologic, or metabolic disorders, which is inclusive of diabetes mellitus. All of these are precautions to LAIV. So I just discussed antiviral agents. Here's some background. Providers may consider prescribing these agents, especially for high-risk persons within the specific intervals. Ideally, it's 48 hours of symptom onset if influenza is suspected or confirmed by laboratory testing. The antivirals amantadine and rimantadine continue to not be recommended because of documented resistance in U.S. influenza isolates, but there are 4 happens to be a resurgence of COVID-19 cases, and regardless of resurgence or not, we do want to make sure that we have capacity available. So universal vaccination with influenza vaccine remains very, very important. And strategies for catching up your patients, it includes reminder recall systems. You can direct these to the patient via text message or postcard. Provider recall is accomplished. Moving to the second graphic, the use of immunization information systems is probably one of the most efficient ways to do provider recall. If you can integrate the IIS into the electronic health record systems that are available, that's a way to do it. And I've already discussed, well, I haven't discussed standing orders yet, but standing orders are a key strategy for raising coverage rates and is something that is very relevant for catching up patients as well. Implemented on a state-by-state process. When a state doesn't have its own standing order, you can use those of the Immunization Action Coalition, and of course, be sure that the usage of the standing order corresponds and complies with your state licensing board requirements. Documentation is a critical strategy. Patients are going to be receiving doses outside their medical home, most likely, and recording the vaccine doses is important to avoid repeat doses at a later point in time. This just helps the patient, the provider, and public health. Routine vaccination is recommended to be deferred in persons with suspected or confirmed COVID-19, regardless of symptoms, unless the criteria have been met for them to discontinue isolation. While mild illness is not a contraindication to vaccination, vaccination visits for the individuals should be postponed to avoid exposing healthcare personnel and other patients to the virus that causes COVID-19. So when scheduling or confirming appointments for vaccination, patients should be instructed to notify the provider's office in advance if they currently have or develop any symptoms of COVID-19. And those persons that had COVID-19 who have symptoms and were directed to care for themselves, they can discontinue isolation if it's been 10 days since symptom onset, if 24 hours have passed since resolution, and 24 hours have passed since resolution of fever without the use of fever-reducing medications, and the other symptoms have improved. A limited number of persons with severe illness might produce replication-competent virus beyond 10 days that warrants extending the duration of isolation for up to 20 days after symptom onset. So you can consider consultation with infection control experts, or you can kind of link to the URL on the slide here, which can take you to our pandemic guidance, which has plenty of details. If a person never develops COVID-19 symptoms, if they had a test, though, that showed they were positive, their isolation period is 10 days after the first positive PCR test for SARS-CoV-2 RNA. Once this isolation period is over, patients can be vaccinated. And again, it's very important to maintain this protection in individuals and communities. Enhanced infection control measures for clinics involve screening patients for COVID-19 symptoms, as mentioned. And then in your clinic, you want to make sure that you're set up to protect your staff, maintain physical distancing, 6 feet apart where possible. Alterations to the physical geography is important, limiting and monitoring facility points of entry, installing barriers to limit contact with patients at triage. Staff should practice respiratory hygiene, and that means face masks for staff, cloth face coverings for patients over 2 years of age if tolerated, and of course, respiratory hygiene also includes cough etiquette. That prevention efforts should be always promoted making sure folks cover their cough, hand hygiene as well, a 60% alcohol hand sanitizer for your patients. Make sure your surfaces are decontaminated, and efforts to limit patient contact with desks and workstations are some other practices that you can use. Some important information about personal protective equipment. So healthcare personnel should use medical face masks. N95 masks alone are not recommended. Some N95 masks have vents that will provide the healthcare provider with protection, but does not serve as source control. So the medical face mask is the method used for source control. Eye protection is recommended in areas of moderate or substantial community transmission. It's optional if there's minimal or no community transmission, unless eye protection is needed for standard precautions. And gloves are specifically recommended for administration of intranasal, which would include LAIV, of course, and is LAIV, or oral vaccines, I'll add. And this is because of the proximity of the hands to the patient's nose and face during administration of these vaccines. Other procedural methods for ensuring physical distancing include scheduling, structure the workflow so that there are well and sick visits at different times of the day, different parts of the facilities. I've already talked about structural manipulation, signs, ropes, floor marking. Some practices have their patients wait outside in their vehicles until called in to receive vaccine. So, of course, we've talked about the fact that if patients have suspect or confirmed COVID-19, they should defer vaccination. If patients are in your office already, you do need to communicate with them the importance of vaccination. Mild illness is neither a contraindication nor a precaution for influenza vaccine, so they can be vaccinated if they're there already. And they're concerned about COVID-19. Again, make sure that you communicate the importance of vaccination and explain the safety protocols and procedures of your office. We've talked about alternative vaccination sites. We have a specific web page on this as well. It's the same URL I showed on the earlier slide. You can link to it. Sites include pharmacies, non-traditional facilities such as schools and churches, curbside clinics, drive-through clinics, mobile outreach units, and home visits are another way to ensure vaccination. Make sure, again, for these alternative sites, your space is large enough for physical distancing. Provide specific appointment times to manage patient flow, avoid crowding, setting up unidirectional site flow. Same practices you would do with your home clinic should be used for your alternative site, and maybe having separate sites for vaccination and COVID care. Our most recent pandemic guidance, the page looks like this. And I kind of blew up the URL so you can see it in larger font. It's www.cdc.gov/vaccines/pandemic-guidance/index.html. And there's a section of the web page that you can click on and sign up to receive information whenever the web page changes. So this is a useful tool that you're notified so you're up to date on any changes to the policy that may be posted on the web page. I'm going to conclude with a couple slides on vaccinate with confidence. And so this was an effort that really began end of the measles outbreaks in 2019. We really started in earnest developing a program to address vaccinate with confidence. In recent years, the outbreaks reached a peak of 1,282 cases in 2019. This was the highest number since 1992. It was a high burden of disease, which almost caused the United States to lose its measles elimination status. So what was clear from the outbreaks is that there are pockets of low vaccination in the United States. And these are areas of isolation or insularity. Low coverage is attributed to this access issue. Additionally, myths and misinformation about vaccines. So the Vaccinate with Confidence initiative is a strategic framework for strengthening vaccine confidence and preventing outbreaks of vaccine-preventable diseases in the United States. There are three parts of this effort. One is protecting communities, which means using every tool available to find and protect communities at risk using tailored, targeted approaches. Empower families, ensuring parents are confident in the decision to vaccinate by strengthening provider-parent vaccine conversations. And then stopping the myths, using local partners and trusted messengers to establish new partnerships to contain the spread of misinformation and educate critical stakeholders about vaccines. And so, tangible kind of product was in the works, and I believe, continues to some degree. It's been a bit overshadowed, but of course, protecting communities really, means emphasizing and enhancing our infrastructure. Like using every tool, as mentioned. Empowering families means perfecting that conversation using the optimal communication approaches. So there was a lot of effort to provide education on that basis. And then stopping myths is just establishing partnerships with the vaccinologists so we can really answer the questions in the amount of detail that's needed to address the misinformation that is out there. I have kind of to conclude my portion of the didactic, I did want to provide the influenza webpage, which is here with the URL www.cdc.gov/flu/index.htm. So this is your stop for all of the flu information that you may need. And in closing, I just want to remind folks that for prevention of influenza, you've heard about many different interventions, gargling daily, zinc, antivirals, but really the best recommendation is to get a flu vaccination. And so with that, I will conclude, and I am happy to take any questions that folks may have.
Thank you so much. I do see two questions here in the chat box. The first is, would you recommend administering Fluad and Shingrix in separate arms if given at the same visit?
We don't have a general recommendation about using separate arms for two different vaccines. We do have recommendations for vaccines and passive products like passive immunoglobulin, HBIG, TIG. And the reason for that recommendation for the separate limb really has to do with just the volume of the material you're injecting. And so you use separate limbs because the passive product usually is a large volume. But you're not going to, affect kind of interaction on a medical biochemical level to any appreciable degree just by using separate limbs. So when we say separate sites, we typically just mean an inch apart so that if there's a local reaction, you can distinguish between which vaccine caused a given local reaction. So it's hard. I can't really say you must do that because it's not going to, if you've made a decision to the two vaccines simultaneously anyway, I don't see any reason to use separate limbs necessarily, but do use separate sites. And again, just to backtrack a little bit, these two vaccines, they contain novel adjuvant. So we don't have data on, kind of why that would be a concern, but just the fact that there are novel adjuvants, some providers are apprehensive about giving these two vaccines together, and so the language of our recommendations do state that you can select you can consider a different product besides Fluad. But if you've made the decision that you're going to use Fluad, you don't have the another vaccine, let's say, then you can use separate arms, but you don't have to.
Okay, thank you. Another question is, does the influenza vaccine interfere with any COVID testing?
I have not heard of any kind of information that would suggest that to be the case. So, I mean, the short answer is no. And I don't know why it would affect a test necessarily. They are different viruses. They are both viruses, but they're different categories of viruses. So I don't see why the actual material that you're injecting would kind of distort a biochemical result that's looking for COVID-19. So the laboratory diagnosis, definitely not. We've thought a lot about, what is the effect of, adverse reactions that are, mild, moderate to severe from vaccination, and what effect that has, generally on the whole process. But we've decided, that, the benefits of getting a flu vaccine really outweigh the adverse reactions that can occur from that vaccine that may be mild to moderate. A fever can occur following influenza vaccine, and so, can there be, complexity with diagnosis, not laboratory diagnosis, but just diagnosis generally? I suppose, but the risk of withholding that influenza vaccine and the effect that could have on hospital capacity really has made us decide that we need to recommend influenza vaccination.
All right, thank you. Is there a concern about syncope with drive-through clinics when having people drive to a separate area to wait 15 minutes with just those few moments of driving from one spot to another?
Well, I mean, I guess, but there's much less concern than there would be if you let them drive away home. So I think we've had this question a lot, and this is kind of probably an answer we've given, is that if you're going to do this type of drive-through vaccination clinic, you should have them drive to a spot and wait 15 minutes. So we've never taken the step of making a full recommendation for the 15 minutes, just because it's not feasible for some clinics to do that. But I think for any drive-in clinic, that's what you have to do, is have them, and they can drive, hopefully they're not driving fast to the spot, and hopefully the spot is not too far away. But if they can pull over to some place where they can wait for 15 minutes, that's a way to implement that recommendation.
Great, thank you. Another one says, when screening suspected or positive COVID patients, is there a specific time period prior to the immunizations? For instance, if they were positive within the last 14 days. Also, how long should you wait before having them come back?
So, if they're, when a patient is screened and has a positive screening result, whether that's a symptomatic screening result or a laboratory screening result or an exposure, screening result, there are guidelines that are kind of laid out for, isolation on our website. And so, I would, the guidelines are kind of, I believe the clock starts with the result, the test result. I'm not sure right now. I'd have to look this up whether it's when the specimen was drawn versus when the result is given. But the isolation precautions are there, so I would use that time course in a circumstance where you're screening someone at a distance and you need to start a clock before they can come in and get their vaccine. So as mentioned, it's a tricky bit of guidance there, because it's mild illness is not a precaution or a contraindication to vaccination. So if someone has mild illness, they can receive a dose of vaccine. So if they're right in front of you, they can receive the dose of vaccine. And if a screening were to occur at that point and there was suspicion at that point, we would say that they still could receive the influenza vaccine. And then you would implement your COVID isolation guidance, I guess, from that point forward. So I've answered this question kind of in the context of vaccination. I'm not sure did I cover all the aspects of the question? I'm trying to.
I think so. Suzanne, please chime in if you still have questions.
Hi, this is Susan. The issue is we're getting a little pushback here. They've been our company is saying 14 days, and some of the providers want like documentation from the CDC about why 14 days matters. So I was just hoping that you had some specific recommendations, but I think it's going to fall back to what our parent company views as the most important for our organization. So,
yeah, I mean, the information about isolation, pulled from our website, they state 10 days since symptom onset and 24 hours since resolution of fever and other symptoms have improved. So that's isolation. I guess, are you thinking for the quarantine? Is that the issue? Is if they?
Well, they were saying that if someone presents and they have suspected COVID symptoms or they've had a positive result within 14 days, we do not give them the immunization. We have them wait. And then I was wondering, how long they should wait. And what I'm hearing is that once they've completed the isolation period, that it's okay to give the immunization.
Oh, that's different.
Correct?
No, I have not seen any guidance saying you should withhold influenza vaccine in that circumstance where they're there in the office. Right? The issue is the issue is protecting the healthcare provider and other patients in the clinic from the suspected COVID-19 that this patient has. That's the concern. There's no concern of interaction, there's no. We say moderate or severe illness is a precaution, but we've been saying that for decades. It's always been a precaution for vaccination, and the reason is you don't want to superimpose an adverse reaction on top of symptoms of that person's illness. Why subject them to two sources of discomfort and pain and misery? Let them get well, and then they can receive their dose of vaccine. But that's a general recommendation, and that's the application of it here for a precaution. But it applies to moderate or severe and does not apply to mild illness. So the issue that, I don't know of any recommendation that says you should withhold influenza vaccine for a period of time in that circumstance.
Thank you for the clarification. Appreciate
it. You're welcome.
All right. I don't see any other questions in the chat box at this moment. So if you have any questions, feel free to type them in or chime in the next minute or so. All right. right. Well, I think that probably is all the questions then. Thank you so much, Dr. Kroger, for giving us that update.
You're welcome.